I'm Suzanne Walters. I'm a pediatric orthopedic surgeon, and my specialty is pediatric and adolescent sports, and I'll be discussing today overuse injuries in the young athlete. In the United States, there's over 30 million pre-adolescents and adolescents participating in organized sports, and this number is on the rise. We're seeing changing patterns in youth sports. Our young athletes are involved in less free play. They're playing at greater intensity levels. We're also seeing higher competitive levels reached at much younger ages, and we're more likely to see our young athletes participating in one sport all year long. There's a lot of players involved in youth sports, parents, coaches, scouts, in addition to the young athlete, and then we're seeing some different goals, kids versus adults. A lot of health benefits associated with being involved in sports, but with this, there's a risk of injury. It's estimated to be over 4 million injuries occurring annually, and of these, about half are overuse injuries. So the benefits of youth exercise: lots of physical benefits, including motor skill development, improving hand-eye coordination, fitness levels, decreased levels of obesity. Psychosocial benefits: improved self-esteem, confidence, motivation, improved social skills, better school performance, and generalized improved feelings of confidence. So the unique anatomy of a skeletally immature individual: the growth plate, which is the physis, the apophysis, as well as the epiphysis, all sites of injury. There's an increased risk of injury during the adolescent growth spurt. There's a mechanism for the bone to grow. We have a growth plate, we lay down new bone. We don't have the same mechanism for all the soft tissues. So essentially, they're being asked to stretch out as the bone is growing. So there's an increased muscle tendon tightness, and as a result, decreased physical strength. The adolescent growth spurt occurs a little bit later for boys than for girls. At boys, it starts around 11, with a peak height velocity occurring at around 13 and a half years of age. With girls, it starts at around 9, with peak height velocity occurring at around 11 and a half years of age. Overuse injuries are chronic injuries. They result from constant high levels of physiologic stress without sufficient recovery time. Risk factors divided into host factors and environmental factors. Host factors are anatomic alignment, muscle tendon imbalance, generalized fitness level, growth and maturation, nutrition, and gender. And then the environmental factors, such as training, conditioning, surface, footwear, equipment, and coaching. So going through some of the host risk factors, looking at anatomic alignment, looking at this athlete here on the right, we can see she has valgus knees as well as pes planus, and this is a setup for patellofemoral complaints. Muscle tendon imbalance, looking at these young dancers over on the right, standing there in their turned out position. Dancers tend to have very well developed external rotators and less developed internal rotators. And then generalized fitness levels. Is this your child or is this your child? Growth and maturation. We obviously can't push these runners on the left as hard as we can push the runners on the right. Nutrition and gender. The female athlete triad's a big one. Amenorrhea, osteopenia, disordered eating. This all sets up some of these young women for stress fractures. And then I want to discuss a couple of the common overuse injuries you're likely to see in your practice. For upper extremity, we'll discuss Little League shoulder. For apophyseal injuries, we'll discuss Osgood-Schlatter's and touch upon Syndig-Larsen-Johansson, as well as Sever's disease. For the knee, we'll discuss patellofemoral syndrome, and then we'll also go over tibial stress fractures. So the first case, 12-year-old right-hand dominant male presents with 1-month history of shoulder pain. Patient's a pitcher and he plays on 2 different teams. He describes dull aching pain that is aggravated by pitching. On exam, he has focal tenderness on the lateral aspect of the proximal humeral physis. X-rays are taken. These are the X-rays on the right side of the right shoulder, and then contralateral films are taken for comparison. So this is Little League shoulder. Treatment: no overhead activities until pain-free, which is usually around 6 weeks. NSAIDs, physical therapy, and repeat X-rays at 6 weeks. and you should notice the physis closing down. One of the most common things I see with patients coming in with one of their parents is that, yes, they may have taken some time off from pitching, but then maybe they're catching, they're still going out, they're playing football with their friends, and they're not really including that in the period of rest. Follow-up x-rays are taken. You can see the initial x-rays on the left, and then how the physis is closing down on the right. I think this x-ray on the left is a dramatic picture. I rarely see patients coming in with x-rays that are quite that obvious. I think you're more likely to see x-rays that really don't look that different. It's more of a clinical exam finding. There's several organizations that have recommendations for pitch counts. I just happen to have put in the USA Baseball 2006. Increasing number of pitches per game, per week, per season, and per year as patients are aging. Okay, next case, knee pain. 12-year-old male complains of knee pain. He plays on a basketball team, no history of trauma, reports 2 months of aching pain in the front of his knee. He's continued to play and says the pain is worse with running, jumping, and squatting. On exam, you notice there's swelling and tenderness of the tibial tubercle. Patient has pain with resisted extension and has very tight quadriceps and hamstrings. X-rays are taken, little ossicles noted here at the tibial tubercle. Not always found, this patient just happened to have it. And he's got Osgood-Schlatter's. Treatment for Osgood-Schlatter's: reduced activity, ice, stretch, NSAIDs, a knee sleeve or strap, if it's helpful. Some patients really find that having that strap there is incredibly helpful, that it takes the stress off of where the pain is, and other patients find it's just adding extra pressure right where the pain is. So I tell my patients, if it helps, wear it. If it doesn't, not necessary. And then on that x-ray that we were just looking at with that ossicle, I'd say that's really the only time this is ever a surgical problem, and that would require excision of the ossicle. The exception more than the rule. I wanted to touch on Syndig-Larsen-Johansson disease, another apophysitis. Typically in 10 to 12-year-olds, patients complain of anterior knee pain. It affects the proximal attachment of the patellar tendon to the patella, and we treat it with NSAIDs. Seaver's disease, calcaneal apophysitis. Patients complain of heel pain. We see this in our runners and jumpers, sports such as soccer. We see this quite frequently. It occurs during peak growth in both males and females. Historically, this was thought to affect males more than females, but I think more of that was, now as we're seeing more women playing the same sports as men, we're seeing it pretty equally between the two. Patients have a positive squeeze test, that's where you're squeezing against the calcaneus, and have tight Achilles tendons. Treat: activity modification, stretch, ice, and heel cups. Another case of knee pain, this time a 12-year-old female ballerina. Complains of anterior knee pain, no mechanical symptoms, so no locking, no giving way, positive theater sign. So when the patient's sitting for a while, gets up to stand, has increased anterior knee pain. Pain going upstairs, so up as opposed to down, and worse with activity. On exam, there's no effusion. Patient can perform a straight leg raise, no joint line tenderness, no ligamentous laxity, no frank instability, and a negative patellar tilt test on exam. Additionally, x-rays are within normal limits. Here we're looking at the sunrise view, and the patella sits very nicely within the trochlear groove. So this patient has patellofemoral syndrome. Patient has anterior knee pain. It's worse after prolonged sitting and pain walking upstairs. And this occurs as a result of weak VMO and a tight IT band, so the kneecap is getting pulled to the outside. Treat with straight leg raises, short arc quads, and avoid painful range of motion. Everybody's a little bit different of where they experience pain. I don't think you can really follow a rule that you should work out the athlete within 30 to 60 degrees or 0 to 30. I think it's important to tell the patient not to work in a range that is painful. Wearing a knee sleeve and arch supports if you notice the patient has flat feet. And our last case, leg pain. 15-year-old female complains of leg pain. She runs track and cross country and has increasing right leg pain. She's continued to run throughout the season regardless of the pain, and the pain's been increasing in intensity. Patient also states she's had decreased performance and her times haven't been so great. So differential diagnosis. The first two on this list I'd say are the big ones that I'd have in my head, the shin splints and stress fracture. Also, keeping in the back of my head, could this be a compartment syndrome? Is a patient describing increased pain after a set amount of time after she starts running, and does it stop a set amount of time afterwards? And then the other thing always to have in the back of your head with any of these patients that are athletes and start telling you they're having pain during sports is, could this be a tumor? Not a huge consideration for most of the patients coming in, but something that I'm also thinking about when I'm ordering x-rays. So further studies, definitely getting an x-ray. If there's any question, need for further study, bone scan and MRI. I tend to be more a fan of an MRI than a bone scan. I prefer the specificity. If the bone scan lights up, to me, it's not giving me as much information. And then if you are concerned about whether or not it's compartment syndrome, of exercise-induced compartment syndrome, then doing compartment pressures. So what will you see on x-ray? Here is a nice little view of the dreaded black line. I think on x-ray, generally on first presentation, you don't see this. In this case, this patient has likely been exercising on this for quite a while, so there's a pretty clear black line there. And then treatment, period of rest. Sometimes this takes several months. If they have made it to my office, I treat the majority of my patients in a cast and non-weight bearing, not just the severe. And then when they start going back, cross-training, swimming, bike, pool running, so that the patient can continue with cardiovascular exercise, but isn't quite putting the pressure on yet until this is completely healed. And the reason for this is if this doesn't heal, this is a big surgery. Having a big rod in a young patient's tibia is not a benign procedure. And this is for the patients that aren't responding to non-surgical. So preventing sports injuries, from good conditioning, training, following the rules, and using the appropriate equipment. And as in many things, balance. Activity versus rest, strength versus flexibility, and dedication versus overtraining. Thank you.
Okay, hello everybody. I'm Naila Coleman. I am a sports pediatrician here at Children's. And I'm going to talk about the pre-participation physical exam. It's hard for me to say that over and over, so I'm just going to say PPE, just so you know. And that's usually how it's abbreviated when you see it written down as well. Okay, so hopefully by the end of this talk, you'll understand the purpose of the PPE and important patient history components of the PPE and things you need to make sure you get when you have a young athlete who comes to you asking about a PPE. Important diagnoses of concern and the reason why we're doing the PPE to begin with. Components of the physical exam that are important to make note of. And any follow-up diagnostic studies or treatment decisions for patients who have something abnormal, whether it's in the history or on the physical exam. And then there are some special medical populations to consider as well. So the PPE has been designed and developed by multiple organizations. There's the American Academy of Family Physicians, the AAP, the American College of Sports Medicine. You never believe how many sports medicine organizations are out there. The American Medical Society of Sports Medicine, the American Orthopedic Society of Sports Medicine, the American Osteopathic Academy of Sports Medicine. So a lot. And there are more than those, actually. So things to consider, and the reason why we're concerned when we do a PPE is that exercise stresses the body. The main organ systems of concern are cardiorespiratory, musculoskeletal, and psychological. Definitely the whole body is stressed, but those are the ones that we are really looking for when we're doing the PPE. So the main purpose of the PPE is just to promote the health and safety of somebody who is physically active. You don't have to play a sport, you just have to be doing something physically active. So if you are a dancer, you're physically active, so you should still have your pre-participation physical, especially when you reach a certain level of activity. So primary reasons for doing the PPE are just to reveal risk factors for things that essentially could kill you or disable you, right? So that could be like cardiac, those are the main things, or somebody who has a musculoskeletal problem that could disable them permanently. We want to find that out before they start. And as well as to detect disease or injury that we need to rehabilitate or treat. Secondary purposes for the PPE are just looking at the general health of the person. How are they? What's their health like? What are their behaviors like? For adolescents who don't always come to see you every year, this is your moment to be with them and to give them anticipatory guidance and to do a complete physical for them as well. Unfortunately, as much as we have this PPE, this is the 4th edition now that we have, there's no research demonstrating that it has any benefits. But it's still recommended and required in most states and high schools and colleges. So the PPE, when you're considering it and when they consider the development of it, they think it should be efficacious, it should be cost-effective, right? It shouldn't cost a lot. It's a screening test. It should be athlete-specific, and it should be flexible. You know, so obviously you want to be able to do it in multiple environments with multiple people performing it and still have the same outcome in the end. It should be confidential, so you have to consider HIPAA and consider FERPA, just because not everyone needs to know all the medical information about this athlete. So if you have a coach and you are not clearing an athlete, all you have to say is, I'm not clearing this person to participate. They don't need to know any more. For the most part, the athletic trainer is considered part of the medical team, so you can share the information with the trainer, especially since the trainer, if it's an injury, will be doing some of the rehabilitation. So logistics. Recently, the new recommendations in the fourth monograph of the PPE are recommending that you guys are the ones who do the pre-participation physical evaluation. I apologize, I'm speaking very quickly, but I definitely recommend that you actually buy the monograph. It's currently published by the AAP. You can also actually find just the physical form on the AAP website or any of the other organizations that I mentioned earlier's websites. The reason why they recommend that you perform the PPE as opposed to having a sports person do it who doesn't know the athlete is because they don't know the athlete. They don't have the history. They might miss something if the athlete does not include it on the form. Also, if you're in one office with one family, you've got more privacy. And in a station-based exam, you've got sometimes several athletes kind of lined up on benches or tables, and there's not a lot of privacy there, so you might not get the same answers or be able to do the same exam that you would like to do with the athlete in your own office. If an athlete does have a station-based exam, so if you are participating in a station-based exam for a local school, you want to make sure that the same person who reviews the history, so gets the questions about cardiac findings in the family or cardiac findings in the athlete, that you're the same person who does the exam, because you're going to be looking for those things. If they're separate, you might not look for what was found in history. For the most part, a pre-participation physical should be performed about 6 weeks before the season starts. The reason is if they need to do any rehabilitation prior to starting the season, they can have it completed and then start their season on time. If they come a week before the season starts, then they might miss several weeks of the season being rehabbed. So like I said, there is no proof that this is helpful. However, it is required, and colleges require one comprehensive exam on the initiation of that person in college. So if it's a freshman. If you transfer and you're a junior, you're going to get a complete exam as a junior. And then they just do updates annually just to see what's changed in the past year. High school recommends a comprehensive exam at the beginning of high school and then every 2 years. So like I said, they are required, but actually states and schools vary on the frequency. So some schools require it every year. They shouldn't actually do it less frequently than the recommended, but some require it more often. Some schools you might find have different forms than the one that is part of the monograph, so you might see something different than what you see if you were to go and look online for the official monograph. Some states allow different providers to perform the PPE. The current recommendation in the monograph is that an MD or a DO be the final decider, but some states allow chiropractors, physical therapists, trainers, PAs, and NPs to perform the PPE as well. And then the documentation is different, can be different. Other things to think about are the cost to the athlete definitely will cost more if they come to you than if they do a station-based exam, especially considering a lot of sports docs like me do them for free in a station-based exam. You have to also think about the degree of risk of the sport. So, base jumping would be different than archery or something like that. So definitely you have to think about that when you're looking at this young athlete and considering clearance. And then the availability of qualified personnel. So definitely if you have certain requirements in your jurisdiction, you need to make sure that you meet them. And then the patient age is important as well. So definitely the older you get, the more it's required. So we've got a lot of kids who are like in Little League, and they're not required to have a PPE. So it's important when you're doing your regular exam, not a PPE per se, just your regular physical exam, that you're looking for these things that could affect their participation as well. Any questions? We're all going. Okay. So the history is extremely important. It's a not too long, per se, but it's extremely important because it can identify about 3/4 of problems that this athlete could have in participating. So it's extremely important that it's done beforehand, but it's also that the athlete perform it with their parent, because a lot of kids don't remember what medical problems they have or had, and a lot of them don't know what family medical problems they had either. So another thing that's important with this history part, since they are completing it on their own, that it needs to be in language that they will understand. And so actually this recent version was changed a little bit as well to make it a little easier to fill out and a little bit easier for people to read and follow on their own. The form has primary questions. So the athlete, have you ever been told you couldn't play or something like that? And then in the monograph, there are secondary questions. Why? When was that? Did you have an injury? Were you rehabilitated? Have you completely recovered? All of those things are important to follow that primary, yes, I had this problem question. The form includes questions about the patient's medical history, current, past, and chronic, as well as surgical history and hospitalizations, previous sports restriction, and it is important to determine whether they've completely recovered or not. So if they did have potentially like an ACL tear, you want to know that they completely recovered, and you might refer them back to the surgeon who did the surgery to make sure that that surgeon would clear them to participate in the sport. So you could complete the rest of the exam and then just hold for that clearance. You want to know what medications they're taking, any drugs, any supplements, and you actually have to ask separately about the supplements because they won't tell you otherwise, any herbs or minerals. And it's important to note them down just because of interactions, we all know that, but it's also important because some substances are banned, and you want to make sure that they're not taking a banned substance, especially if they're at a certain level of competition, that would be important. If you don't know what banned substances are out there, you can go to the U.S. Anti-Doping Agency or the World Anti-Doping Agency, either website. So it's USADA or WADA, that's how they're abbreviated. You want to know if they have any allergies, any anaphylaxis or urticarial history. And there are lots of kids out there, believe it or not, who have exercise-induced urticaria, so it is important to ask those questions. And if they do have that, trying to kind of give them some anticipatory guidance in that respect. Cardiovascular, that's one of the main concerns I mentioned earlier. You want to know about a personal or family history of cardiac problems. Have they ever passed out during or after exercise? Have they had chest pain during or after exercise? And I ask them both just that way because they won't always tell you otherwise. You want to know if they have any dyspnea during or after exercise and any palpitations during or after exercise. Is there any history of hypertension? Have they had a murmur? Did they have it resolve, or is it still there? Is it followed by cardiology? Were they cleared? You want to have all that. And if you're unsure, send it back to cardiology. It's better to be safe than sorry. Do they have a cardiac infection, or have they had one in the past? And have they had an abnormal EKG before? Now, you're not going to do an EKG today, but if they have had an abnormal one before, you would refer them as well. In terms of the family history, you want to know if there's a family history of heart disease, any sudden death before the age of 50, and any unexplained death. So did somebody drown? Nobody knows why. Did somebody have a seizure for an unusual reason or no reason at all? Is there a family history of Marfan syndrome or syndromes that are like that? You want to get all of that history. And all of these questions are actually on the form so that you don't have to kind of come up with it out of your head. It's all right there. Musculoskeletal history, you want to know, have they ever missed a practice or a game because of an injury? Have they ever been diagnosed with a sprain, a strain, a tear? These are all kind of the similar things, but you're asking them in different ways so you can make sure you get the history. Ever had tendinitis, a fracture, or dislocation? For Down syndrome patients, you want to know if they have a history of lateral axial instability or if they've been evaluated for it before. Have they ever had an x-ray for an injury, an MRI, a CT? Have they had injections for an injury for treatment of pain of some kind? Have they been in rehabilitation? When did they finish? Were they complete? Have they ever used crutches or been using a brace, or do they currently use a brace? And have they ever been casted for something? These are just all different ways of getting at the same thing. Have they had a problem? And then you want to know, does it still affect them now? Respiratory-wise, you want to know if they have asthma. And another way of asking that is, do they cough, wheeze, or have problems breathing during exercise? Do they use an inhaler during or after exercise? Just the same way of getting the same question, the same information. Is there a family history of asthma? Do they have one organ of some kind, so one kidney? Do they have one testes, one ovary, one eye? You always want to get this information because that might alter the sport you allow them to participate in or you recommend they participate in. Have they had a viral illness within the past month? or do they have a viral illness now? Are they having a fever? These will all just affect their participation or their safe participation in sports. In particular, mono, especially within the past month, is a no-go, unfortunately. Do they have any skin issues? Rashes, sores, chronic skin problems, herpes? You want to know if they have it now, have they had it in the past, do they get it often? Just things to consider when you're clearing them. Have they ever had a head injury? Have they ever been diagnosed with a concussion? How many? Any recently, or has it been years since their last one? Have they had any seizures? Do they get headaches with exercise? Have they ever had any numbness or tingling or weakness after an injury? These are all things that will make you think about whether you need to rehabilitate them, have them go to see a specialist, or just say you can't participate, we're going to have to wait and do more testing before we let you participate. Have they ever had heat illness? This is a good opportunity to provide anticipatory guidance on whether they need to be more careful in a hot environment. So have they had any cramps when it's hot outside? Have they ever felt ill? Have they ever passed out or felt dizzy when it's hot? They need to be more careful or potentially need to be screened. Situations of concern are hot and humid environments, so maybe not today, but maybe this weekend might be a concern. If they're drinking caffeine, that could be a concern. If they're poorly acclimatized, so if I just moved here from Alaska and I went to go play this weekend soccer outside, I might have a hard time. The environment is different. If they have excess body fat or a large body size, these are all reasons to be concerned that they could be subject to heat illness. Sickle cell disease and sickle cell trait also can be have problems with the heat. There is recent evidence showing that people with sickle cell trait, we always worry about sickle cell disease, but that people with sickle cell trait have exertional sickling with submaximal activity. So not the sprinters, not the marathoners, but the middle people. They can sickle, and that can lead to rhabdoacidosis, acute renal failure, multi-system organ failure, and death. And we've had that happen several times over the past few years. So now that the NCAA recommends that sickle cell status be documented. So if you're seeing somebody who's going into college and you're doing a pre-participation physical, you need to make sure that you document that sickle cell status for them. Are they overweight or are they underweight? Do they have a history of either? And how do they recover from that status? What are their immunizations like? That's really important for sports that might involve exchange of bodily fluids, even minimal, like boxing. So you want them to have their hepatitis B on board. And any psychosocial issues that might be affecting them. And do they have any questions for you? Right? You always, this is your opportunity to talk with them, to meet with them, and to do that anticipatory guidance. So you want to make sure you get their questions answered. So there are some things to make sure about the female athlete or to be concerned about. And you want to make sure that they don't have a history of stress fracture or dislocation. You want to make sure that they haven't missed a practice or a game, and you really want to find out why and what was the history behind that. What's their nutrition intake like? What are the calories that they're eating now? Are they doing anything to restrict their calories? Are they taking enough calcium and vitamin D? And what's their menstrual history like? So when do they start their periods? What's their flow like? Is it heavy? Is it light? And how many have they had in the past 12 months? The important number to have is at least 10. If they've had less than that, then you have to be concerned that they're not having enough hormonal control of their menses. Other questions that you might find in the PPE are you happy with your weight? And as much as I've done them, the girls are always never happy. And the boys are fine, even if they're actually overweight. They're fine with their weight. Which is, I know, it's, I guess, stereotypical. Are you on any special diets? Have you ever been diagnosed with an eating disorder? These are just all things just kind of be concerned about in your female athlete. When you're counseling about nutrition intake, you want them to have about 1,300 milligrams of calcium a day, 400 international units of vitamin D a day, although that might change. And then depending on the age of the young lady, it might be 8 to 18 milligrams of iron per day. One thing that they might not tell you in their medication list is if they're on a birth control pill. A lot of young ladies don't necessarily consider it a medicine, but that might actually alter your perception of whether they have a menstrual dysfunction or not. So if they are on a pill, you want to ask why they're on a pill, because if they're on a pill to monitor or to help regulate their periods, then you still have to think menstrual dysfunction and think about the female athlete triad, which is low energy availability. So if a young lady athlete is not eating as well or as much as she should for her sport, that happens frequently if you go from one level of competition to the other. So they might not voluntarily restrict their calories, but they're just not eating enough. So they just don't think to eat more. I've never had that problem. That's the first one. It used to be anorexia. It's not anorexia anymore. It's just not eating enough for what you're doing. The second is menstrual dysfunction. It used to be amenorrhea. It's not. It's just a change in their menses that's not normal. And the third is low bone mineral density. It used to be osteoporosis. It's not. So we've kind of modified and made it a little less restrictive to be classified as a female athlete triad. These are all things to think about when you're asking those questions. So then you get to the exam, and there are certain questions actually that you want to make sure you ask this athlete. And you want to make sure the athlete is alone without their parent, because you want to get an honest response that's not hindered by the athlete not wanting their parent to hear this concern. So you want to ask, are they stressed? This is extremely important for college freshmen or incoming freshmen for college, because they're in a new sport, that they might have practices every day. They're in a new school, they might be alone. And you want to know that they have a backup, somebody to talk to, and you want to kind of help direct them appropriately. Are they feeling depressed? Do they feel safe? Like I said, this is your time to talk with them and to get to know them, so you want to make sure that everything is okay in their social environment. You want to ask if they use drugs, if they smoke or use smokeless tobacco or drink alcohol. You want to know if they're doing any steroids, supplements, or ergogenic aids, and what are they. And then you want to just know if they're being safe out there, if they're using seatbelts, if they're wearing helmets, and if they're using condoms. So on to the exam. So we'll get, bless you. So we'll get what we usually have, right? So the height, the weight, we'll calculate the BMI. We'll do the vital signs, heart rate, and you want a sitting brachial blood pressure. You want to look at their eyes, you want to get the visual acuity, and you want to get their pupils. And you want to make sure that you note what their pupils are like, because not everyone has symmetric pupils. And so if you have a young athlete who has asymmetric pupils, and nobody noted it, and then they have a head injury, and now somebody's looking at their eyes saying they're asymmetric, they're going to think it's because of the injury, and it's not. That's how they are at baseline. So it's important to note that, as well as to note their response. Do just a general ENT exam, lung fields, and then cardiovascular, you want to look at the rate, the rhythm, listen for a murmur, and feel their femoral pulses for symmetry. Important things to note with a murmur are how it reacts to various maneuvers. So if you hear a murmur, you're just not going to stop there, because there are some, we all know there are benign murmurs. But you also want to know how it responds. So you can do a squat to stand. So when you squat and you go up to stand, you have decreased cardiac return. And so you can have an increased murmur with hypertrophic cardiomyopathy, and you can have a decreased aortic stenosis and mitral regurgitation murmur. So that's just one way of kind of getting getting a feel for what you're hearing. Deep inspiration causes increased right heart murmurs, and Valsalva is actually the same as squat to stand. You want to feel their abdomen for any masses, any tenderness, any organomegaly. For boys only, definitely you need a private area, and if you are a female physician, you need a chaperone, but you want to do a testicular exam. You want to note whether there's one or two, whether there's an undescended one or not, if there's a mass and if there's a hernia. This is also a good time to do some anticipatory guidance on the testicular exam, because the adolescent time frame is the beginning of the concerning age for testicular cancer. So you can give some anticipatory guidance there as well. Look at their skin. Do they have any rashes or any lesions or anything like that? And then the musculoskeletal exam, which Dr. Walters talked about earlier, is brief. And unless you have one or two joints or something that you're looking for in particular, you can be very brief. It's actually very quick, and I'd be happy to go over it after. I'm not going to have time to go over it right now. But you're looking for contour, symmetry, range of motion, stability of the different joints, and strength. So for the young lady, other things to be concerned about are parotid enlargement or dental enamel erosion, right? Bulimia, right? Look at her vital signs. Is she hypotensive? Is she bradycardic? So prolonged anorexics have this problem. Does she have epigastric tenderness that makes you concerned also about bulimia? The GU exam is not part of the PPE for girls, so if it is needed, then you'll have to have a separate exam for that. And then you want to look at her skin. Is it dry, sallow? Does she have lanugo? Are her hands and feet cold? Does she say they're cold all the time? Does she have decreased subcutaneous fat? And does she have a Russell sign, which is kind of a callus on the knuckles of the dominant hand associated with bulimia? So any additional screening that you might do would be based on the history, on the exam, on the sport, and on any regulation that revolves around the sport. So for wrestling and teenage boys, there are certain body fat percent limits under which you can't go or you can't participate. A lot of young boys will try and make weight, but they can only make weight to a certain point. After that, they can't play. Endurance and flexibility testing for certain sports and certain athletes. Cardiorespiratory testing for athletes of concern, right? So you might have an EKG. It's not recommended universally in the United States, although Europe and particularly Italy recommend it. An echocardiogram or pulmonary function testing, depending. You might do drug testing or infectious disease testing, depending on the jurisdiction, the state, the school, or the sport. So boxing has a requirement for HIV testing in all of their athletes, which makes sense because especially the more higher level athletes, there's a lot of blood out there. And then you want to see about getting ophthalmologic testing, audiometry, or tympanometry testing. So when you're all done and you're looking at the history, the exam, any additional testing you did, you also want to think about the static and dynamic demands of the sport and the nature of contact of the sport before you say, you can play. So static sports increase the blood pressure load on the left ventricle, so like weightlifting. Dynamic sports increase the cardiac output required of the left ventricle, so it's like running. So you can clear somebody to participate within anything. Or you can say, I want you to work on your therapy while you're starting your new season. You can also say, you know what, I want you to see the cardiologist first before I clear you. So everything else is fine, but we need you to do this one thing before you're cleared. Or you can say, no, I don't want you to play this sport or this sport because it's too hard for you. Or you can say, I don't want you to play any sports. So I had a young athlete who actually I saw for back pain, and in the history I got from him, not in the PPE, he had a history of syncope and chest pain and dizziness with exercise. He had a family history of a family member dying in her 40s. I think it was his grandmother. And he had a murmur, and he had a history of mitral valve prolapse. So I referred him to cardiology, and he actually had biventricular cardiomyopathy. Now he's like 17 or 18, so you don't want to ever say no sports at all. But the cardiologist said nothing competitive. So he can do stuff, just general things outside, but he can't ever play in a team. And one thing to always be concerned about is the psyche of that athlete. So for the rest of his life, he can't really play a competitive sport, and he was in great shape otherwise. So you want to make sure that you're following them, because athletes actually equate not making the team equally, or even more so, than the death of a friend, than separation of parents, than failing a grade in school. So it's important to them. So you have to make sure that you're following them as well. And then young ladies, you want to make sure if they do have a concern for triad that you're treating them not just you, but a whole team, because there might be more involved. You might need endocrine, you might need a bone health specialist, you also might need a psychologist. So I'm going to talk about specific conditions that might make you say, you know what, let's get you referred, or let's say, no, you're not going to play. Or you might play in only these sports. So cardiovascularly, there's structural heart disease or symptomatic cardiac problems. Those require cardiology referral. So hypertension, it's one of the most common things in the PPE that can be abnormal. They're restricted if they're stage 2, so over the 99th percentile, or if they have end organ damage or symptoms of end organ damage. You can also always refer them to cardiology if this is your first evaluation of them with such an abnormal blood pressure. Benign functional murmurs, they can play if they're asymptomatic. Dysrhythmias, they can play if they're asymptomatic. Hypertrophic cardiomyopathy, they can't play in a lot of things, even if they are asymptomatic. It is the most common cause of death or sudden death in our athletes in the United States, and they can do kind of those low-intensity sports. So they can do archery, they can't do basketball. Diabetes, people who are well-controlled can play most sports, as long as their diet is controlled, their glucose control is being followed, and they're well hydrated. Also, depending, I guess, on how long they've had diabetes, you want to make sure that you're looking for diabetic complications, like neuropathy or something like that as well. People who are obese or even overweight, you need to make sure that they are acclimatized to their environment. You can also give them some ideas on how to get their weight to a healthier level, like increasing their physical activity, improving their diet, changing their lifestyle. Sickle cell disease, if their status permits, they can play anything that's not high intensity or high exertional, and obviously you want the environment to be appropriate for them. And then like I mentioned with sickle cell trait, they can play, but you have to also be worried about that submaximal exercise. So concussions are the most common head injury, or serious head injury that we see in contact and collision sports. The number is actually underreported. We really don't know what the true number is because a lot of young people are going to say, no, I'm fine. And if you're only going by symptoms, that's you don't always know exactly how many have had it. But the number ranges from 300,000 to 2 million every year here in the United States. And 400,000 in football alone. So if you have a football player, you want to make sure you're getting that history if they've had a head injury. The one thing that people still struggle with is that concussions are not something you can see, like an ankle sprain with a big swollen ankle. You can't see that. There's no brace you put on that. It's something that's happening on the inside. It's a functional disturbance, not a structural disturbance. And because of that, people they kind of ignore it, or they kind of ignore the symptoms. So it is important to kind of talk to them about. 90% of people who have a concussion never passed out. So they got hit and they're running off this way and everybody else is going this way. And that's how you know that they might have had a concussion. They're not laying on the field unconscious. And then common symptoms in concussions can be cognitive, somatic, or affective. So they could have amnesia for the event or before or after. They could be confused. They could feel just like they're just not really there. They could have nausea and vomiting or headaches that are persistent. And then they can be emotionally labile. So where usually they're nice and cheery, now they're mean-spirited. So it's important to kind of get all of that history. And if you have any questions about concussion and concussion evaluation, you can always go to the CDC has a great website called Heads Up Concussion, and they have a lot of information on there that you can give to your athletes as well. So they can participate if they have had complete resolution of concussive symptoms for at least a week. Now, it is hard sometimes to kind of get that history from athletes. So you really kind of would prefer to have them have neuropsych testing before their sport and then after their injury, just so you can kind of see what the difference is. When they do get to go back, you want to start in a graded fashion. So you want to go from having done nothing to doing some light aerobic activity, to doing sport-specific exercises, to doing drills that are still non-contact, to full contact practice, and then, provided everything is still fine and they are not having any symptoms, they can play in a real game. And the things that we worry about, especially in our young athletes, are second impact syndrome, which is really, it's a diffuse cerebral edema that happens in a head injury in a young athlete who has not been incompletely recovered from his previous concussion. So it's extremely important that you make sure that they are completely clear from that. Other things are post-concussive syndrome, which is just kind of persistence of symptoms, for an unknown amount of time, and then persistent neurologic deficits where they might not ever reach their potential. Or if it's an older athlete, they might have decreased in what they're able to do. Other neurologic conditions to consider when you're talking with athletes are, have they had any burners or stingers? It's almost like if you hit your, bless you, your funny bone, same kind of thing, you get tingling and for a little while. Well, football players can get it if they get a kind of a distraction injury with their neck and their head, so they could tackle somebody and then they come off and they're feeling funny and you see them kind of waving their hand. And usually those go away pretty quickly, but once they're asymptomatic, they can play. So you want to make sure they're fully strong and they have normal sensation on each side. However, should they keep having this happen, or if you talk to them and they say, oh yeah, all the time I get those, you want to make sure that they're evaluated. Same thing with cervical spinal cord neuropraxia, also called transient quadriplegia. So these are the athletes who kind of get hit and then they're down and they're not feeling anything, they're not moving at all, and then later they're fine. They could potentially have a cervical spinal stenosis, which could make it more likely that they had this condition to begin with and could lead to them being restricted from sports. There are athletes out there who have seizures. They can play if their seizures are well controlled. They can't play in everything. Obviously, there are certain things that are high risk for them, like diving, right? That's not good if you have a tendency to have seizures, gymnastics, those kinds of things. And headaches. Athletes with headaches can participate, especially with migraines. You want to get a history of when they're getting their headaches, if it's exertional, like benign exertional headaches or primary exertional headaches, just to make sure there isn't something behind those headaches, because definitely they can be associated with Arnold-Chiari or other malformations. You want to make sure they don't have that before you let them play. The most common ophthalmologic condition or disturbance on the PPE is visual disturbance. So you want to make sure that at least that if one eye is less than 20 over 40, you're giving them some counseling, because You want to make sure that good eye is protected. But you also want to make sure that that other eye is evaluated. It can affect how they play, and you don't want them to have an injury in their good eye. They can also have a detached retina, have had a history of previous eye surgery or a serious eye injury in the past. In addition to acuity problems, you might want to have them have an ophthalmologic evaluation for somebody who had surgery already or some injury before. There are eye guards out there that are allowed in most, I think if not all sports, that people can use if they do have that problem. So asymptomatic athletes with any kind of bloodborne infection can participate, although, like I said, some sports might restrict them, like boxing. You want to consider the type of activity, the risk of transmission to other people, and the athlete's current health status, and obviously maintain their confidentiality, right? So the coach doesn't need to know, right? HIV, only blood is a